All right, thanks everybody for being here today. Again, thank you to the Project ECHO members for inviting us. We can go ahead and go to the next slide. So what we really wanted to talk about today is really kind of a down and dirty introduction to pediatric palliative care and really get into where it can benefit patients and what kind of are the expectations that you can have for pediatric palliative care. So our objectives are really looking at it, identifying those tasks, describing when it's a good time to use it, and evaluating myths and assumptions, which is probably going to come from a hopefully robust discussion that this will prompt for everyone. Go ahead. So pediatric palliative care really is about preventing, identifying, and treating suffering in children with serious illnesses and their families, very family focused, and the teams that care for them. It's appropriate at any stage of the illness. It actually works best if it's initiated very early, and it can be provided together along with disease-directed treatment. And a lot of people don't understand the interchangeability with the word hospice and where it fits in with hospice. So hospice is a component of palliative care. And if you look at the diagram, it really shows you that hospice focus is really at that last 6 months. That really hospice was started as an insurance benefit and is completely insurance benefit driven, as being defined as a patient having a potential for death in 6 months or less. And the services and resources are really focused and centered on end-of-life issues. Still providing in-home assessment, pain and symptom management, psychosocial and decision-making support, and of course then grief and bereavement support. But you can see along that trajectory that as curative and life-prolonging care becomes less prevalent in the continuum of care, where those sorts of cares become more important, but you can see how they work together. Go ahead. So a lot of people think in pediatrics, is this really necessary? Because a lot of rare diseases are what we are talking about affecting these children. And so unless somebody's actually been personally touched, they don't understand how many kids are still affected in the US every year. So every year in the US, more than 50,000 children die. Anywhere between 500,000 to 1 million are living with and suffering with complex and chronic conditions. More than 10,000 children a year are diagnosed with a cancer, which is the leading cause of disease-related death in children. And 40,000 children are diagnosed with congenital heart disease every year. And we have more than 80,000 infants born severely premature. So you can see on this graph that there are a lot of different implications in what is affecting life expectancy and quality of life of children. A lot of people think only cancer would be the thing that would be the end of life care or a life-threatening disease. And you can see that cancer really is only about 4%. There is a larger percent with unintentional injuries, for example, and then complications that come from medical interventions are close, along with congenital anomalies, run closely thereafter. So next slide. So pediatric palliative care really focuses on family-centered care. It's really requires an interdisciplinary team, and there are lots of tasks involved in that, and we're going to break them down kind of by the keyword of those tasks going forward. So communication is probably the number one task that people don't understand. Suffering and preventing suffering requires good communication. You've got to proactively and aggressively identify problems and challenges, understand the illness, and be able to, even though we don't have a crystal ball, anticipate as much as possible what types of things we need to be prepared for. Exploring hopes and setting goals with families, talking about advanced care planning, and really being there in that judgment-free way of helping families to explore and make the decisions that they have to make. So it also requires a lot of care coordination, and that is a huge part of pediatric palliative care, is really coordinating things and helping families navigate and walk their way through this journey. Collaborating with the other providers and specialists. As we know, because kids are different than adults when it comes to the hospice benefit, it's a concurrent model where thanks to the ACA 10 years ago now, we have this concurrent care being available. It really helps with these key tasks pull together and improve the communication between all of the specialists without making families have to pick and choose which are the things that they think they need to stay current on, or having to pick and choose what they think they might have to give up on. So really facilitating logistics for all their medical and social needs, partnering with community programs to bring resources in, identifying those community resources. Next slide. So it also requires intervention. You've got a medical team in addition to an interdisciplinary team that really focuses on eliminating physical suffering, psychosocial suffering, spiritual suffering, bereavement support following, bereavement support, sorry, not just following, but anticipatory and following. Family support, support to the team of those caring for these fragile children, and community support as well, participating in things such as this and helping to educate the community to bring that additional support that's needed around these types of care. Next slide. So a child's suffering and health and function changes over time, and this is just to kind of show that if you look at the end of life trajectory for adult patients, it's usually a pretty steady decline, and kids have a lot more of this up and down. So I really want to look at some key points in that for interventions, and so we've kind of marked them here, and on the next slide we'll go through that in a little more detail. Go ahead. So A is really where it could be the beginning of the diagnosis, or it could be that they had a diagnosis that they didn't really expect to have a poor prognosis, but they had some sudden clinical change and they've got some worsening there. And then B is where they've really got lingering symptoms, and you begin to see anticipatory grievance. You've got parents that are now grieving the loss of the goals and dreams that they had for this child. You know, they may have really wanted him to be if it's a boy, an athlete. He was going to grow up to be the next big thing in the NFL. And all of those goals and dreams that they had thought about through that whole pregnancy really comes to fruition, and they really start to have some reality setting in here. And then they'll just kind of truck along, and then in C, you really start having some decline. So then you start really noticing more things that need intervention, and they need more of the medical support kind of at that point. And then on D, you really get to where, okay, we've got those things under control, and we had a little bit more of an uptick, but we're now steadily declining, and need to talk about how are we coping with that? What kind of decisions need to be made? Do we need to have decisions about how much intervention do we want? It's really important in the older children to really have them included and do a lot of self-determination at that point. And then of course there on E is really when we realize that we've reached the point where our hope is for now not recovery, but that we're looking at imminent death, and we really want to explore what does that look like? How do we make it the most comfortable and most supported death that we possibly can, and transition them onto ongoing bereavement support for the loved ones who will be left. So let's talk about an example. So in the possibility that somebody didn't have a case that they wanted to talk, I did write up a case study that Nicole and I kind of worked through. And so we'll share that with you, but I also would then like to open it up so that anybody can ask questions, or it may trigger you to think about a case that you would like to share. I wanted this to be outpatient focused because I think most of the participants are on the outpatient side. So we have a 5-year-old named Jamie who is a hypoxic ischemic encephalopathy from a near drowning. He spent about a month in the hospital and he was discharged a couple of months ago, and the family moved to Nevada in order to be closer to family. So he's now presenting to the pediatric practice to establish primary care. He arrives with his mom and his 2 siblings. He is alert and he's in a specialized wheelchair. He has a G-tube in place. He receives feeds through the G-tube. Mom reports that he's been evaluated and he aspirates, so he can't get anything by mouth. He also has a tracheostomy in place since his initial injury, and sometimes he uses oxygen at night. So as a physician or nurse practitioner in that pediatric practice, physically you do your exam and notice that the muscle tone is floppy. He doesn't have the ability to purposely reach, stand, or sit independently. But you also notice during your exam as you're moving him through that he'll have spasms, and he often cries when he does spasm. So he seems to have a lot of drooling and not really managing his secretions well. Developmentally wise, Mom said prior to the injury or the accident, he was a typical developing 5-year-old finishing up his kindergarten year. He was on track with all of his milestones and development, did not have any developmental delays prior to that. Cognitively, facial expressions have really led the family and parents to believe he is understanding most of what he hears. And he recognizes voices, turns, and vocalizes sounds to his family, his siblings, and friends. His vision is intact and he tracks. He has seizures, and they're pretty well controlled on medication, but he does still have small seizures occurring daily. So we know his hearing is fully intact. He cannot speak, but he is able to track and blink and appropriately responds yes and no with blinks. He communicates anger, frustrations, as well as happiness with his facial expressions and vocalizing. And he's able to cry. Sometimes it's not clear, though, if he's neurologically irritable or if he's having pain, because he also cries with those apparent muscle spasms. So a lot of people would just think that this is a kid who's probably going to live a really long time like this, and this wouldn't be a good candidate. But the actual answer is that he is completely an appropriate candidate. And I'm going to turn it over to Nicole now to talk about some of the further evaluation that that is the benefit from including him in this kind of care.
So yes, this patient is appropriate for palliative care and would receive support from an interdisciplinary team. That would include the medical support, which we would provide physicians or an APRN who would come out for a visit every 60 days for just a routine surveillance, or PRN visits for their if there are any clinical changes. They would be assigned a registered nurse as a case manager who would be providing a weekly visit, as well as any support from an LPN or CNAs as needed. The program would also be able to support with medical equipment. And alongside the medical support, the palliative care team is also able to provide psychosocial, emotional, and spiritual needs of not only the patient, but the siblings, the parents, and any family that may be living in the house or close to this child. The psychosocial and spiritual care team members include a certified child specialist, social workers, non-dominational chaplains, as well as bereavement counselors and other supportive therapies such as music therapy and massage therapy. All disciplines offer a great deal of support to this patient and family and can only do this through effective communication, which is the key hospice advantage, expectation, and benefit. In this case provided, little Jamie would have a further psychosocial assessment that revealed a more in-depth look at the family needs. So we discovered that mom is the primary home carer and used to run a part-time business from home, but after the accident had to put that on pause. Dad is a full-time employee at Chick-fil-A as a shift manager. There is a 7-year-old sister who is about to start 2nd grade, and there's a 3.5-year-old younger brother who's never been enrolled in any school programming. They moved here to Nevada to be closer to family, but the family that they moved close to doesn't really understand the day-to-day that the parents are going through. Financially, the family lost income from mom's small business, and their medical bills and the high deductibles have led family to express that they have a financial hardship. Socially, the family now has their local family, but they're still trying to build that relationship, and they're still trying to create a life here and build sustainable support systems. Mom does not have any friends left here and feels very isolated and does not get out of the house often. The family only owns 1 car, so dad takes that to work, and the siblings do not have any access to engaging in activities, and mom has expressed concerns about not knowing how to talk to them about everything that has happened over the last few months, and also concerned about how to address these situations with school. The family has had a past history of being Jehovah's Witnesses and are not actively involved and haven't been involved for the last 2 years with their church. They seem conflicted with some of their decisions based on the things that they were taught when practicing. So when we look at our interdisciplinary team, I want to give some examples of how this team can support this family. So our social workers will be able to connect the family to assistance, financial assistance, such as energy assistance, food assistance, and other programs to help try to alleviate the financial burden that they are facing. Also maybe helps mom look at applying for unemployment. They help the family look for programmings that might be able to help them purchase equipment and other items that weren't covered by insurance. And they also provide emotional support for the parents, monitor the psychosocial risk, and connect the parents to support groups to build their support system. A certified child specialist will help work with the patient to provide opportunities for expression, developmental support, and build patients' coping skills. Working with the siblings to support their understanding of the patient's medical diagnosis and equipment being used by the patient. Helps the siblings continue and engage and play with their brother and how to do that now. And help create opportunities for them to express themselves and their feelings and their questions about what has been going on. The child specialist will also work with the parents to help gain confidence and strategies to support in how they have those conversations with their children and the family and their family members about their new normal. They can help address the difficult questions that the siblings may bring up and how to support the balance of their other children's needs as well as their child's new dependency. So social workers and child specialists can work together to support the wishes of the patient, siblings, and family as a whole, to support the creation of family legacy items and provide opportunities for engagement in community activities and events. Chaplains are also available to provide support for this family and help them have the opportunity to think through what their spiritual and religious needs are. They can also provide individual counseling, but as well as connect them to community and things that might be around to help them build that support system. The interdisciplinary team will also refer to other therapies as needed, provide bereavement support throughout the care, and facilitate coordination of care. This includes regular communication with the primary care team, coordination of services across all disciplines, including acute hospitalization, home hourly nursing, school needs, therapies, community resource application assistance, and arranging family meetings with input from the entire medical team when concerns arise. This is done in respect of the child and the family's wishes and with the goal to improve the quality of life for the patient and the family members. So in general, this is how an interdisciplinary palliative care team can support this case. And we would like to open it up for some questions.
Yeah, great presentation. Thank you. Yeah, other comments or questions from the group about this case? Please feel free to unmute yourself or write in through that chat box.
There has to be somebody out there with some challenging cases that they're not sure if they're appropriate or not. And this is your opportunity to say, hey, could this one be? And we kind of all brainstorm together at how we can improve care for that patient and family.
Patty, go ahead.
This is Patty. Well, I don't have a case. I just had a question. Could you remind me how old this child is?
5.
Oh, he's 5. Okay. In these situations, I know that a number of children in this situation, they go to school. Is there an opportunity for him to go to school?
There is. So he was in his last 2 weeks before he finished kindergarten. So it would actually be getting him ready, but integrating them into a school environment with a special 504 plan or IEP is something that the interdisciplinary team actually all has input into. And sometimes even one member of the interdisciplinary team would go support the parent and participate in the meeting with the school district for that. Some school districts are well equipped and have that, but all the school districts have a legal requirement to help us accommodate these children back in for that social integration more than anything. And some of the services are actually available then because they have PT, OT, and speech therapy related to the school district as well. That's a good question, Patty. Thank you.
Yeah, great question, Patty. Thank you. Ashley?
Yes, I was going to not have a scenario or a question, but just say I've been doing peds, been on the peds team at ProCare for a couple of years. And I really appreciate the deeper understanding that you provided, Angela, of how, Carousel is sort of palliative care and how that fits into a hospice organization. And then also Nicole just sort of explaining how all of the disciplines can come together to support one another and the different roles that each play. So I think overall it helped me to get a better idea of what the PEDS palliative program's purpose is and what it looks like.
I think it's important to talk about not that I want to start a political discussion, but the ACA, that Affordable Care Act, was the driving force that allowed these kind of services to be developed so that they're concurrent. It developed concurrent care. And it's sad that it's 10 years now before we're really starting to see programs be able to develop and utilize it. But it's because, as in all things government, it wasn't ever really very clear. And so there were a lot of people who had a really hard time understanding how it fit in. And I think that I attended a webinar yesterday with a couple of PEDS palliative care coalitions, and we're going to begin to see that there are payers out there because so much of hospice care is payer driven. We're going to see payers starting to change and not try to fit kids into that adult model of how the hospice benefit began. And there will be a dual Medicare traditional standard hospice care, but there will also be a carve out for children where they're using the terminology of concurrent hospice care. And I think that will help people to further their understanding. But as typical in the medical field, things are several years delayed of actually getting fully implemented. And so I guess I feel fortunate that we're at 10 years and not 15 years before we're really getting it. But this summer was just the 10th anniversary of us being able to start concurrent care. Thank you, Ashley.
Dr. Laws?
So thank you very much for this talk, especially for those of us who don't see a lot of pediatric patients in our facility. Our PEDS patients tend to be shipped down to Sacramento. But can you explain, you had mentioned self-determination and when to kind of bring those children in who are cognitively intact. into that conversation, and about what age do you see that being appropriate?
It really depends on the maturity of the child, because I've seen some teenagers just not be at the maturity level where they're really able to participate in that conversation. And I've had 7-year-olds who were totally fine with that conversation and guiding. So I think it is, again, a very individual thing, but I think that the interdisciplinary team is usually very focused on having conversations regularly with parents and letting parents be the best guide. You frequently have parents who don't want any conversation about that in front of children, and that's usually how we begin. And we just continue to have the conversations about the importance of understanding that they know more than we give them credit to know, and getting patients ready to be able to allow the child in on the decision, because their natural instinct, of course, is to want to protect them. But it's very individual. I've had it happen very young, and I've had it not be able to happen at all in teens, that they just weren't at a place where they could actively participate in it. So there's not a good answer for that. It's completely individual and what you pick up on as the provider.
And I would say as a certified child specialist, that's kind of our role, is really working with that patient to see what is expressed and be able to make that assessment about what is their ability to participate in those conversations and at what level. So if you have access to a child specialist, or they were hospitalized and had that service, you can then ask, go back to that system and see what their assessment was, because oftentimes that child is bringing out their comments, their questions, their misconceptions, or their reality of what they want as their option, and then it's being able to bring that to the parents and be like, look, this is what your child is expressing. So being able to use that, it's really, for me, I've had children as young as 6 tell me that they no longer would like this certain treatment, but they would like this path, and they don't want to tell their parent because they don't want their parent to cry in front of them.
Yeah, do you have, Dr. Laws, do you have a child life specialist available to you at the hospital you work at or work with?
That's a really great question. We don't, have peds. Our emergency department sees everyone, but we ship everyone down. So unless it's directly in the emergency department, we transfer all of those patients out, even though we're a very large hospital.
Yeah.
For Sutter, all of those pediatric patients we send downtown.
Sutter has to have a child life specialist at one of their locations.
Yeah, it would probably be in
say
Sacramento.
to them as a resource and say, hey, can we call you when we need your input? And my experience with child life specialists has always been that they're happy always to help, and that they don't become child life specialists because they they just want to get rich or anything. They come because they have the mission of making a difference in the life of children. So,
and it's really about getting that voice heard, and that's really the forte of the child life specialist.
A comment here
that was a good question.
A comment here from Dr. Bayan, just saying his experience with terminally ill children is that they're often much more mature than the adults that he sees on a day-to-day basis. He's seen children comfort their parents.
Yes, indeed. Just as Nicole shared, that's often the conversation that we have to have with parents, is that Johnny's not talking about this because he knows it makes you cry. And we need to somehow normalize that and make it okay to cry and have the conversation at the same time about it. And that's often, the child life forte is to identify what developmental level that kiddo is really at, and give them that through therapeutic play, give them that opportunity to really open up and share what really are the worries. I think sometimes as the provider, we try to have those conversations with them, and we always talk about, is there anything that you're really scared about? But oftentimes through therapeutic play with the child life specialist, we'll get somewhere further than we're able to get just at doing an exam.
Great discussion, everybody. Thank you. Any other questions, comments?
Yeah, so I have one comment and two questions. So thank you for giving this talk. This hits very close to home. Our daughter, well, she had palliative care and she was in hospice for 18 months. And it was longer and better than anyone could have imagined. And everything you described is just what what we experience with palliative care for kids. And it's why I changed. I'm a mid-career physician. I'm an adult neurologist, but that's why I'm here doing this fellowship. My daughter was 4, and she told us very clearly what her wishes were. My questions, number one, what you're describing is wonderful. What is coverage like in Nevada in general, and Reno in particular?
Yeah.
Kind of services. My second question is, I just started talking to my program director, and for a QI project, I think I'm going to try to develop a curriculum for pediatrics, for the pediatric palliative care for the adult program. I'd love to talk to someone who can help me with that.
My gosh, please reach out to me. I would love to help you with your project. So we're fortunate in Nevada, although it has taken several years. Like we started working on this when I was doing my doctorate. ProCare as a organization helped me with my doctorate project to educate the Medicaid program here and help reach out to payers to understand. So it is still paid under the hospice benefit because I'm imagining it's going to take us several more years to catch up to where other states are already doing this separate carve-out concurrent care program. But we are fortunate enough that they have gotten the understanding, and for the last 6 years now, I think this program has been able to grow exponentially. With that being said, we're still, based on the data I did, only servicing about 25% of the total kids who would qualify in the state for this kind of care. There is a small program that's part of an adult hospice in northern Nevada that does children as well. So we are fortunate that we have it, but coverage is under Medicaid benefit, and it still requires a lot of education on our part to payers about this whole concurrent care concept. Remember, the ACA only requires Medicaid, Medicare to open up and cover this concurrent benefit. And so the burden is on us to talk other payers into understanding and following that same model. And those who hold the purse strings aren't real anxious to do that sometimes, but persistence is paying off. It is starting to be more recognized. Thank you for sharing your personal story too, Michelle. That brings up a very good point that this type of care confuses again, because quality of life does improve and the kids oftentimes do better and live longer when you add this extra layer of care and support in there. And that's contrary to what traditional hospice benefit and hospice model has been. And so that has been our biggest challenge, even though it's the biggest blessing that we get to see that we made a difference in the life and the process and the journey for that family and gave them some memorable time.
Thanks for sharing, Michelle. Other comments, questions, scenarios from the group?
I see a comment too from Christy in there about being new to hospice and palliative care. Welcome, Christy. Welcome. And we cover the whole valley in Nevada, so please feel free to reach out, and any help that we can be to you, we are happy to do so.
This is Patty. I just had one quick, kind of quick question. So for Child Life, I know I encountered them at Sunrise actually when adults were dying, the Child Life would come over and help the children. So how widespread are Child Life programs? Because I haven't seen them in other hospitals.
So here in Las Vegas, they're at Sunrise, UMC, St. Rose, and the children's
Care for the kids.
Care for the Kids. So, but in turn, all over the U.S., we are huge, and especially in California, they have huge Child Life programs. So a lot of our kids are also being supported by Child Life when they go to get medical treatment in California as well. I am the first within a hospice program here in the Nevada area. But Child Life is practicing within palliative care and hospice all across the state.
Okay, thank you.
But of course, there's not enough of them, and we're really blessed to have one. And we're not letting her go anywhere.
Question here from Virginia. Do you have many kids that graduate off palliative care?
Oh, Virginia, that's such a great question. So oftentimes I tell people that that's one of the biggest difference between traditional hospice and concurrent hospice care, that is palliative, is that they very often graduate, and it's not a funeral at that graduation. It's that they graduate because they've done so well and they exceeded expectations. And again, like that disease trajectory, kids are so unpredictable. They oftentimes will do better than anybody anticipated. So I always say crystal balls would never work in pediatrics. I can't imagine how they could possibly keep up with being able to figure these guys out, because they very frequently surprise us. And Nicole just said we've got two coming up that are going to graduate off service that are doing well enough that they no longer meet. So yes, we celebrate that.
What percentage do you think end up graduating? I mean, I've seen very low numbers in adult hospice, but do you see higher in pediatrics?
If we were able to get the 100% of the kids that were eligible, we would probably have a graduation rate. I would anticipate around 15 to 20% would be my guesstimate. But because we're missing still so many of those kids that could really qualify and benefit from this, I think right now it's probably 2%.
We're only getting the more difficult.
Yeah.
People are able to recognize that, oh, this is definitely a palliative.
Yeah.
Great discussion, everybody. Any other last questions or comments?
Anya, you're on the pediatric team. Am I about right? You think it's only about 2% graduation? It's a low number?
Yes, for me, actually, it is those the only two pediatric patients that are going to graduate. And it's amazing because both of them spent some time in NICU. She was going to talk about AA. She was 6 months in NICU and trach, G-tube, vent, you name it, pulmonary hypertension and all of the stuff, and slowly decreasing the sildenafils and weaning off the vent. And with the speech therapy, she's able to take some PO. Now she's taking most of her feeds PO. She still has a G-tube for hydration and medication administration, but she's doing great. She's going to the cannulation on 825. And the other one, same thing. She was G-tube, vent, trach, you name it, and she's graduating on September the 3rd.
Exciting. Yay! And we do graduation parties just like they do no more chemo parties. So it's all good.
We do. I wanted to thank Nicole in every single way because she is in my right hand to go to if I need questions, even for siblings. And there's like 6 siblings in one and a newborn. So there's so many adjustments, and Nicole could go in and just explain on everybody's level, teenage level to the 4-year-old and 3-year-old. And through Child's Play, she is doing amazing, especially there was a situation of end of life care too, when you walked in and you were able to made it the situation so beautiful and so healing for the whole family, because the baby was born the way, you know, not everyone expected, but it was so beautiful. And you gave that connection between brothers and sisters, between the baby that was actually literally dying. So it was really amazing. And that's such a healing for parents to see that, because every parent wants have dreams and all these things and all the emotion from A to E. Everything is, you know, like crushed, and they cannot cope with it. And Nicole comes and she goes, okay, let's do this. And it's just like, okay, separately talking to siblings. And it's just amazing. And she's such an amazing person and resource to our team.
Thank you, Anya. Thank you so much. And I would love to see Child Life grow within palliative care in Las Vegas and everywhere. Well, there's a lot that we can provide during these difficult